This is a wonderful opportunity partnering with us to advance our mission for better health in the community. And you're in for a treat today because we have Medical University of South Carolina graduate, former medical officer in the U.S. Navy, and Iraqi war veteran, as well as celebrated radiation oncologist at AMED, Dr. Leander Cannick.
Good morning, everyone, and thank you for inviting me. It's a pleasure to be here. As Michael said, one of the missions of AMED is really to get out and educate as many people as possible about the importance of health and wellness. And of course, the Osher Institute, I've done some research, and of course, the mission is lifelong learning. And so we're glad to be here today. And like I said, I've learned a lot about your program and your organization. The only thing I wish was different was the age limit. You know, you have to be 50 years old to join.
That is not true. Any age can join. Any adult can join.
Really? So I'm going to join. and there's a trip to Alaska in August that I'm going to hopefully I can join you guys on and see Alaska. That's one place my wife really wants to go. So hopefully we can join you all and make that trip. Today we're going to be talking about arthritis. Now I'm an oncologist, and so today we're not going to talk about any oncology issues unless someone has a question. But arthritis is a very common issue. Now imagine if I were to ask the question, how many people here have any joint pain or knee pain or shoulder pain? We'd see a lot of hands go up, I would imagine. And guess what? My hand would go up too, because I was in the military and I was a young person and I did a lot of things on my knees when I was younger. And so right now, if I were to overdo it, you know, I'd have some knee pain and I'd have to kind of take it easy and do the ice, the rest, the Motrin. And thankfully, I'm at the point where that typically does work. But then we get to the point where those conservative measures don't work anymore. And, you know, there's other options, injections and things like that. And I don't want to, tell the whole story, but what I would say is that low-dose radiation therapy is very effective for treating osteoarthritis, especially for people who've already failed first and second-line treatments and don't want to have surgery.
You say osteoarthritis. Is there arthritis anywhere other than the bones?
Yes, well, there's different types of arthritis. There's rheumatoid arthritis, which is an autoimmune condition that can impact any joint. There's also inflammatory arthritis that are caused by infections as well. But osteoarthritis is the most common type of arthritis. First thing I would say is I'm not here to sell anything, right? I'm not trying to sell radiation therapy to anyone, because we have a lot of patients that have conditions that it's really indicated and it's the only treatment. So arthritis, there's different treatments, but I would say that the best person to tell their story will be someone that had arthritis and had the treatment. Now this is Mr. White, and he's just one example of a person that we could use to tell the story. Now Mr. White is a very active person. He's in his 70s. As a younger person, he was involved in martial arts. He's an avid fisherman. Believe he's a hunter. He's a very active person. And he had arthritis for a long time, and he tried different things. He tried injections, and they worked for a while. He tried the oral medications. They worked for a while. But he got to the point where nothing was working. And thank the Lord, his daughter works in the radiation department. And she said, "Dad, we're doing this treatment for arthritis using low-dose radiation therapy. You should give it a try. I think it'll work." And so that should tell you one important thing. So if his daughter is recommending it, it must be something that really is effective. And that's one thing that I would also add is if I wasn't seeing these results myself, I wouldn't believe it. His story is more the rule than the exception. And so what he says was, this is his words, in quotes, he says, "You wouldn't believe how many people I've told. It's a big change, a great change." And that's true. I've seen one of his friends. He sent a friend that had knee pain. He's already started treatment, and he's had improvement of his symptoms after just a couple of treatments. And he goes on to say, "Oh Lord, yes, it's made a difference for me," he says. "I can go to the mailbox without excruciating pain. I can go up the stairs without pain. I can walk up a driveway without excruciating pain." And so, and that's what we really hope for people who have tried different options, that this is another tool in the toolbox wherein people can have results without a lot of side effects. And that's always the question, side effects. And so this is where the magic happens. All right, this is a linear accelerator. It's called the Edge, and it's the latest generation of radiation therapy treatment machines. They're called linear accelerators. And what happens is a patient will lay right here with their head here, and the radiation therapy, the X-ray therapy will come out of the head of the machine. So there's no cutting, there's no IVs, you don't have to, there's no special diets. Essentially, it's just like getting a chest X-ray or a CT scan. So there's no pain, nothing to do to really prepare except to show up. What is radiation therapy? So it's called ionizing radiation, and it's called ionizing because what happens is, this is an electron orbit, and as electrons move from one orbit to the next, that's called ionization. And so throughout that process, we have the formation of radiation therapy. And essentially, what we see on the right is an X-ray being generated. And so radiation therapy, in the way in which we use it, is nothing more than X-ray therapy. And we use these X-rays to target different parts of the body, whether it's the knee or the shoulder, the breast, the prostate, the head, the neck. That's essentially is what we do. We do X-ray therapy. Now on the right, we see alpha particles and beta particles. And so what would fall into that category would be things like protons. So you might have heard of proton therapy. And so proton therapy is another type of radiation therapy, which we don't do at our department, but it's done in a few centers around the country and around the world. And so how is radiation therapy dose measured? And so for the treatment of radiation therapy in osteoarthritis, we use what we consider low dose radiation therapy. And so radiation therapy is measured in a unit called the gray. Just like most things in America, we have our own special units called the rad. But for most places, the international unit is called the gray. And so we say we're going to give a low dose radiation therapy. We're going to measure that in a unit called the gray. And radiation therapy can be delivered in either standard or hypofractionation. So if we say standard fractionation, that's a smaller unit. If we say hypofractionation, that's going to be a larger unit. And when we do low dose radiation therapy, it's actually in a unit that's even smaller than the standard fractionation. So for most things, we'd use 1.8 or 2 gray per day, whereas for low dose radiation, we'd use 0.5 to 1 gray per day. So that's why it's low dose radiation. So you can just imagine we're a radiation center, so the majority of what we treat are going to be cancers. And so, and these are common things that we treat with the common dose that we would use, just to get an idea of what's a typical dose of radiation for a typical condition, right? And so for lung cancer, typically we do 60 gray and 30 fractions. So that's a standard treatment for lung cancer. If we're going to be doing hypofractionation, where we do a larger dose per day, we would do 50 gray and 5 fractions. Prostate cancer, again, it'll be 70 gray and 28 fractions, or as many as 79.2 gray and 44 fractions. So you can just imagine, that's a lot of back and forth, 6 weeks, 9 weeks of daily low dose treatments. And again, I say low dose treatments, so that's not the low dose, ultra low dose that we use for arthritis. Again, breast cancer, skin cancer, 66 gray and 33 fractions. A lot of what we do is palliative treatment. So if someone has brain metastasis or bone pain caused by the cancer traveling to a bone, in those cases we do palliative radiation therapy, and those doses again are different. So 30 gray for treating the whole brain, or if we're doing a tiny lesion in the brain, we'd use a big dose of radiation at one time. So it'd be 18 gray in 1 fraction, 20 gray in 1 fraction. Now, radiation therapy has been used to treat other benign conditions for some time. Now, for today's purposes, we're talking about essentially arthritis, but there are other things that we use radiation therapy for. And again, just looking at the dose for arthritis, it's going to be 6 gray and 6 fractions, or as little as 3 gray and 6 fractions. So we compare that to breast cancer, where it's 60 gray and 30 fractions. We're talking about 6 gray and 6 fractions. So that's an entire magnitude less. And so when we talk about side effects, that's why the side effects of radiation in this case, in these settings, are going to be very low because the dose is very low. And so keloids, keloids is a hyperproliferation of scar tissue. So after surgery, the surgeons remove the keloid tissue and excise and leave a neat incision. After that, we do radiation therapy to decrease the risk of that keloid scar being reformed. Plantar fasciitis is actually a success story in radiation therapy. So the success rate in plantar fasciitis is about 90%. And so that's a very common condition, a painful condition, and it's very effective. And we have a slide coming next that really shows a celebrity that was treated for plantar fasciitis, and he had really great success. There's other things that are listed too that radiation is used for in benign settings. And so who knows who this person is? Who recognizes this? Yes, he's a sprinter, but not just any sprinter. He's actually the fastest man in the world, Usain Bolt. And this was Usain Bolt in 2008, before the Beijing Olympics, before his first gold medal. So he was diagnosed with plantar fasciitis. And it was questionable whether he was going to be able to race or not. But you see where he is. You saw our second slide was the linear accelerator, our edge. And that's where he is now. He's in the radiation center. And he got treated with radiation therapy for his plantar fasciitis. So it's really questionable whether or not he was going to be able to race or not. And that slide, and that slide is blurry for a reason, right? I know Michael's back there nervous. Oh, Dr. Cannick gave a blurry slide. It's not the slide that's blurry. Usain Bolt was just so fast, So this was his first gold medal. So Jamaica owes radiation oncology a thank you for that. But it worked for him. Osteoarthritis is very common. So 32 million Americans are affected. Second leading cause of disability. Currently, 1 in 7 Americans have been diagnosed. And honestly, I thought the number would be higher than just 1 in 7, because I can just think of my family, my parents, and I have relatives that are diagnosed. So I would have thought that number would have been even higher. But the lifetime risk of developing it is 46% in the knees and 25% in the hips. And women have a higher risk of diagnosis than men. And here's a picture that shows the lifetime risk. And again, women have a slightly higher risk than men, with the highest joints being impacted are being the hips and knees, and 47% of hands in women. And so this is a typical presentation: pain with activity, early morning stiffness, crepitus, and that's sort of when you bend your knee, you can feel that bone-on-bone kind of interaction. You can just kind of feel that and hear that. Risk factors are going to be, like most things, increase with age. We looked at the female sex being a risk factor. Obesity is going to be a big one. Just the weight on the joints is going to increase the wear and tear on them, as you could imagine. Prior injury, malalignment, and also genetic predisposition. So if you have a family history of it, you're more likely to be diagnosed with it. And so osteoarthritis management here. So we can see at the bottom of the pyramid moving up. So as we increase the severity of the symptoms, we dose escalate the treatment. So at the bottom of the pyramid, where maybe sort of where I am, just educate myself, exercise, and that sort of thing, rest as needed. But then as you move up the pyramid, maybe rest isn't helping, knee brace isn't helping. That you want to use topical NSAIDs, capsaicin, those kinds of things. Then we move on up to oral medications, Tylenol, Motrin, those things. And then, of course, everything that we do has side effects. And so you can't just take Motrin every day, because what's going to happen, you have an increased risk of ulcerations and those sorts of things. Short-term relief with steroids, which do offer some benefit, but after a while, those things stop working, and there's a risk of injury to the cartilage with injections into the joint space. So you're limited there as well. And of course, the final step would be surgery. so total knee replacement, shoulder replacement. And so where the radiation fit in this algorithm, ideally, it'll be before knee replacement or shoulder replacement. So if someone got to the point where, hey, I don't want to have a knee replacement, or I want to put it off, or if I'm not a candidate for a surgery, that's where radiation would really come into play. And so this picture actually shows us what's going on actually in the joint. And so we look at the picture on the left, we see it's kind of divided in half. On the left side, we see the healthy joint. You see the normal joint capsule, synovial membrane, healthy cartilage, subchondral joint. That's all normal. However, if we see someone with severe arthritis, the picture looks more like the right side. We see the osteophyte or bone formation. That'll show up on the X-ray, right? So we get the X-ray, we'll see the little bones in the X-ray in the joint itself, and we'll have inflammation of the membrane, inflamed joint, and degraded cartilage. And so that's what, if in the schematic format, that's what we would see. And of course, you can imagine that's going to be very painful. You won't be able to, of course, your doctors are going to tell you you need to exercise, 30 minutes, 5 days a week. But it's going to be pretty hard to do if your knee feels like the way that looks, perhaps. And again, so if we look at the cellular level, what's going on is all this inflammation is caused by all these chemokines and pro-inflammatory cytokines. And that's what's really driving this inflammatory response. But on the bottom of the picture here, we see the anti-inflammatory cytokines. And so ideally, you want a good balance, right? You need both of these to be going on at the same time. So if our body has an insult, we need some inflammatory markers to tell ourselves to, hey, slow down, maybe repair these things. And then we need the anti-inflammatory cytokines, sort of the good guys, to help us repair what's going on within the body. And where radiation works is down here in the anti-inflammatory arena, and it decreases the risk of inflammation. And this is just a schematic that really shows all of that. And so if you look here, if you'd actually take the time and read all these different steps, essentially the end result is radiation has an anti-inflammatory impact on the joint space. As a radiation oncologist, what really excited me about this picture and this mechanism was step 4, right? And it says it reduces the production of radioactive oxygen species. In radiation oncology residency, we have a whole section on radiobiology, and they teach us, how does radiation therapy really work to fight cancer cells? And the way it does is by creating these radioactive oxygen species, right? So that's what causes the double-stranded DNA break. That's what really fights the tumor cells within the body. But in this mechanism, using low-dose radiation therapy, it has the opposite effect. So it reduces these radioactive oxygen species, which decreases inflammation. And so for me as a radiation oncologist, that was kind of an eye-opening piece of information, because that's really the opposite of what we've all been taught and learned. We have this conceptual anti-inflammatory window where at low doses, less than the standard dose. So the standard dose is going to be 2 gray per day, and that's where you see the inflammation occur. Whereas at low doses, less than 1 gray per day, is that the anti-inflammatory window. All right, so that's where we want to be if we want to treat radiation therapy with low doses. So that 0.5 to 1 gray per day. And so the question was asked, what is the history of low-dose radiation therapy in arthritis? And so first publication of radiation being used to treat arthritis was in 1898. There were 4 patients. They had arthritis and all had a complete response in their pain. And so that was 1898. So that was many, many years ago. So again, this is not a new treatment. It's just new to us again. 1933 was the first well-described clinical investigation that actually described the fields, the doses, and how we should best use radiation therapy to treat patients. And from the historical data, about 2/3 of people have improvement of their pain with these treatments. The best information that we have about radiation therapy comes from the German experience. And so it's actually the German Cooperative Radiation Therapy Group for Benign Diseases. And so they studied not just arthritis, they studied other conditions as well, plantar fasciitis and amongst others. And what they found was that, again, radiation therapy is effective. And today, if you go to Germany and look at their radiation centers, 30% of all their cases are for benign conditions. And so what's the American experience? And so radiation therapy was used very commonly in the United States up until about the 1980s. So what happened? Well, other treatment options became available. Things like oral medications, joint injections became more commonly used. And so radiation therapy sort of fell out of favor. There are also some studies published in the 1970s that suggested that radiation therapy wasn't quite as effective. But then, like most studies, if you kind of dug down in the detail of those studies, and in retrospect, we know that the way that the radiation therapy was delivered was not optimal for treating osteoarthritis. Now, if we look at this study here, this was published in 2022 by the Vanderbilt University Medical Center, and then asked the question. This is the Radiation Oncology Journal, so it's our professional journal, and then asked the question, why aren't we using radiation therapy as like other countries? And the answer was essentially, we should be. It's an effective treatment, and it's really just underutilized. So it's no reason why we shouldn't be, especially given the great results that we're seeing in other countries, Germany and England and other countries around the world. Now, in residency, my residency director would always ask the question, what's your batting average, right? And so we read all these studies about other places, how well they're doing, which is very helpful. But it's also very reassuring and even more helpful to know how you're doing it at your institution or in your department. And so we treated our first patients in 2023. And since that time, we've treated this more than 25 now. That's probably, it's probably more so 35 patients. But at this time, there are 25 patients. We treated 43 sites. 4 patients had been treated multiple times to the same site with different locations. So you ask the question, can you receive, treatment to a shoulder and a knee? And so yes, and we had, 4 of those patients that had to receive treatment to different sites. And overall, about 80% of the patients had improvement of pain. And so that's really good. And, and as far as side effects, we really, haven't seen much in the way of side effects either. That has shown that these treatments provide pain relief in up to 60 to 90% of patients with essentially no side effects. And so you can just imagine if you have a treatment that has this kind of results, it'd be, front page of the New England Journal of Medicine. But that's really good results. 62% of patients have persistent pain relief after 38 months of treatment, so it's essentially three years. One of the largest studies looking at 1,185 sites, small and large joints, showed a 65.6% decrease in pain at 8 weeks. And so in this study, they said 8 weeks, right? So 8 weeks, they had 66% improvement of pain. But in our experience, sometimes we've seen patients that have improvement before they even get done with treatment. And in cases of insufficient response, where you bring a person back at 8 weeks and they're still having pain, you repeat the second course of treatment, and then about 60% of those patients have improvement of pain. These are actually pictures from our department. And so we've treated different anatomical sites. Again, the most common site is the knee. You can look on the far left side there. It's just a CT scan of what a radiation field would look like. And over here is actually the dose coverage. And so the orange is where the radiation therapy is going. And then one of the benefits of treating the joints are that there's not a lot of sensitive structures around, right? So there's no heart or lungs. Essentially, it's just the knee and skin, which can tolerate the higher doses in this of radiation. Yes, sir.
You say improvement in pain. That doesn't mean the pain is totally gone. It's just improved, right?
Well, I would say that's probably an accurate statement. That was probably an accurate statement. Significantly improved. And again, so these treatments are not going to change the integrity of the joint. So if you have bone-on-bone pain, your anatomy is not going to change, but the sensation that you feel, the pain relief should be better. You know, like Mr. White in his testimony, he said he was able to walk to the mailbox without excruciating pain. You know, when I saw him when I initially saw him, he said his pain was a 9 to 10, but after treatment, he said it was about a 1 or a 2. So it's a lot better. So we've treated people with shoulder pain, hand pain. Now this was a lady that really enjoyed sewing, and she had a lot of hand pain that really interfered with her ability to sew and knit. And so she, again, the hand is difficult because, you know, it's really hard to do injections in the hand. And so it's really not really an effective treatment. And so this worked great for her. So she actually did 2 rounds of radiation and started physical therapy. And now she had a significant improvement of her symptoms. And she's getting back to sewing and knitting, and she's, you know, again, she'd be someone who would have a positive testimony to share. Now this is a very special ankle. This is not a normal ankle. This is one of my now retired nurses in our department, and she had ankle pain, and she came in for treatment. And she's someone who's very learned in radiation therapy. And she had 2 treatments, 2 courses of radiation with significant improvement of her ankle pain. Of course, the hip as well, a common place that we see patients with arthritis. And again, we treated this patient, and she had improvement of her pain. And again, plantar fasciitis. This was a young physician who tried different things. He tried injections, and he tried physical therapy, and still was having significant pain. And so we did radiation therapy, and he's a lot better now. As far as toxicity, I said before, there's essentially no real risks of significant side effects with these treatments because the dose is so low. And so in a review of over 1,000 patients, only 1 person noted mild skin redness. And so I wouldn't think that the side effects should prevent anyone who needs these treatments from having these treatments. It doesn't interfere with your future desire for a joint replacement. So if someone needed a knee replacement, they could have radiation therapy, and then later, have the joint replaced if needed. Now, whenever we think of radiation therapy or talk to a person about radiation therapy, we tell them that there's a risk of a second cancer caused by radiation therapy. And normally that's going to be a risk for a young person. If you have a 5-year-old, 10-year-old, 15-year-old, their cells are still growing and dividing. So there's a risk maybe 15, 20 years later that they can have a second cancer caused by the radiation. Now, if we look at low dose radiation therapy, where the doses are going to be so low, that risk is going to be very minimal. And one publication would suggest that if we extrapolate from CT data, abdominal CT scans, which are very common, the amount of radiation from a CT scan will be comparable to what we would see from low dose radiation therapy. And the risk of a radiation-induced cancer based on age, at age 25, it'll be a roughly 2 per 1,000 people. And so as you increase that age 70, that risk is going to be 0.3 per 1,000 people. And so the risk of a second cancer is very low. And actually, from the German experience, they've had no cases reported of a second cancer caused by radiation. And they have the longest published experience. So future direction, I would say, as all things in oncology or in patient care in general, we should always shoot for collaboration with other specialties, rheumatology, orthopedic surgery, pain specialists, primary care, physical therapy. And we always work together to give the best treatment possible. And of course, we look at the German experience and these other experiences. We really want to focus on how we in the United States and South Carolina and Anderson County can really provide the best care for our patients. Again, low-dose radiation therapy is most appropriate for people who have failed first and second line treatments, also for people who are older than age 40. And so if you're 30, perhaps you would try to do all these other things until you exhausted all other treatment options before treating with radiation therapy. But after about age 40, I think it's a safe age where we don't have to worry about a second malignancy caused by the radiation therapy. In conclusion, despite clinical use in other countries, low-dose radiation therapy is underutilized in the United States. Recent studies have shown moderate to long-term pain relief. It's cost-effective, it's covered by insurance, and again, multidisciplinary treatment approaches are necessary. And so it's important we work together. I always tell my patients that they're the most important member of the team. So we have all these doctors and nurses and other folks on the team, but our patients are the most important members of the team. They let us know what's working. We are, as patients, our own best advocates, and we know our bodies better than anyone else does.
Can anybody just call and get an evaluation with you, or does that have to come as a referral?
It doesn't have to. I mean, we can see, if someone has a diagnosis of arthritis, we can see them as a self-referral. Well, this has been wonderful for me to come out and see you all.